Okay, well, it's 12:01. I'm going to get started. And usually this gives people a little more time to come on board. So welcome, everyone. For those of you who don't know me, my name is Marc-André Pigeon, or Marc-André Pigeon, and I'm the director of the Canadian Centre for the Study of Cooperatives. To start us off in a good way, I'd like to acknowledge that we're coming to you from Treaty 6 land. This is the territory of the Cree, the Saulteaux, the Dene, Dakota, Lakota, and Nakota, and it has been for millennia. It's also the homeland of the Métis. We're grateful for this opportunity to work and live on this land, to share in its bounty, reflect on its beauty, and reaffirm our commitment to the shared, necessary, and ongoing work of reconciliation in universities, in the cooperative sector, and in our communities. In a few moments, you're all going to hear about a robust evaluation of one of the Saskatchewan's first cooperative community clinics, one that's been working for more than 60 years and has been consistently responding, innovating, growing, and evolving to meet the changing healthcare needs of its members and the community it serves. The Saskatoon Community Clinic is a bit of an anomaly in Saskatchewan, and even in Canada. I just did a little count, and there's roughly about 12 or 13, primary care cooperative clinics in Canada. But this is the first, if not one of the first, if not the first, in Canada. And it delivers team-based, patient-centered care with a cooperative, patient-led governance model. And that's a big contrast with the vast majority of the clinics in Canada, which are physician-led and governed and operate on a fee-for-service basis. And so for this work, we did this evaluation study. Saskatoon Community Clinic asked us, oh boy, it was about three and a bit years ago, maybe 4 years ago, to kind of work on an evaluation of their model. And what do we see? How do we know, whether what they're doing is effective or not? We needed someone of exceptional skills to lead this work. And so we looked far and wide, and then we found her in Belgium, of all places. So lucky for us, our featured speaker today, Dr. Coralie Darcy, was looking for an international experience to enrich her perspectives. I think those are quotes from Coralie somewhere along the way. And the idea of Saskatchewan was intriguing enough to get her here. So in September 2023, she moved to Saskatoon to accept the John Tsutoyama Graduate School of Public Policy's prestigious Houston Family Research Fellowship, and to begin work on this evaluation. So in this talk, Coralie is going to share some findings from the evaluation and highlight some of the challenges and opportunities around its governance. And just a bit of background on Coralie. She holds a PhD in social and political science from l'Université de Liège in Belgium. Her research focuses on health systems, organization, public policy, and processes and governance. She approaches her work with curiosity, empathy, and rigor, and she's been core to this project ever since she got here. I should also note that a lot of this work has been co-led by myself and Hai-Jen Mu, Dr. Hai-Jen Mu, an economist here in our policy school, and that Coralie and Hai-Jen have been part of an interdisciplinary team doing studies on patient medical home models in Saskatchewan, which resemble but are not the same thing. Somewhat resemble the Saskatoon Community Clinic. I could go on and on. Coralie has been just a delight to work with. She's an exceptional scholar. She's become a good friend and trusted colleague, and is a really important part of our team here. So before Coralie shares some of her findings from her work, I'm just going to set out the scene here. Coralie's going to talk to us for about 15-20 minutes. After that, we're going to play it by ear, whether we do a breakout or not, depending on attendance. But typically, we try to splinter people off into groups so they can have a conversation about the presentation. Just a final note, if anyone's having any technical difficulties, you can email Dasha Guliak. Dasha is taking Stan's role today, and we're really happy to have her here. Dasha, can you wave to folks just so they can see you?
Yes.
Perfect.
Hello, everyone.
Thank you, Dasha. And she's going to be there to help you if you have any challenges. Finally, this session is recorded. You probably already noted that, and will be shared with everyone who registered for the event. We'll be mailing that out after today's talk. Coralie, this is enough from me. It's your turn to shine. Please begin your presentation.
Yes, thank you, Marc-André, for the very nice introduction. I'm just gonna share my screen first. Is that working good? Yeah.
It's great.
So yeah, hello everyone. Thank you, Marc-André, and the whole team for the opportunity to share some of our results of that fascinating research we've been conducting for years now. I just wanted to say first, I'm not a, as you've heard, I'm not a co-op expert. So that's my first co-op I've been working on. And yeah, it's been fascinating, but I am also excited to hear your comments and perspective and ideas after the presentation. So yeah. Um, so maybe just the plan of the presentation. So I'm just going to say a few words about the research very quickly, a few words of context about the creation of the Saskatoon Community Clinic. I'm going to call it SCC. It makes things easier. And then a few research results. Obviously, I'm going to have to focus on the governance challenges of the organization. The report we produced is what, 100-page long, Marc-André? So yeah, it's going to be tough to share everything in details, but yeah, just to highlight some of the main findings, and we can complement if needed. And Marc-André and Natalie can also help with that if needed. So just a few words about the research. So here's the research team. So as Marc-André said, the project was co-led by Haijen and Marc-André, and the team has been really good to work with. We worked mainly around three big work packages, I call them. The first one was an analysis of the health data comparing SCC patient with non-SCC patient in Saskatoon, a matched panel of patients. I did not work on that work package. We then conducted a patient experience survey, again, trying to compare SCC patients' experience with non-SCC patient in Saskatoon, again, matching them with regard to some criteria. And then we conducted a qualitative analysis of SCC model of care and of governance. The goal was to better understand their model of care and governance and the challenges that they have been facing and are facing currently. That has been an extensive work. We have around 30, 40 interviews. I cannot remember the exact number, and lots of observations and as I said, an extensive descriptive report. So yeah, about this Saskatoon Community Clinic, I wanted to share a bit of its story because I'm not sure everybody knows the clinic. So as Marc-André said, it's a 60-year-old, more than 60-year now, primary care co-op. So it has been created in 62 when the NDP government planned to expand public insurance to primary care, which made Saskatchewan family physician not happy at all, and they promised to go on a strike if it was the case. So that's what happened. 1st of July 62, they went on strike, and around that date, citizens all around Saskatchewan associated came together with family doctors who were in agreement with the ideas of NDP's plan. They came together and they created co-op clinics all around the province. The goal was to obviously serve the population in a time of crisis. So I cannot remember how many co-ops have seen, like it was dozens, right, of co-ops seeing like being created. They've been recruiting doctors abroad. They've been looking for facilities and equipment and all of that. So yeah, huge amount of work. Um, the strike lasted for 21 days, and weeks after that, we have to say that the context for those new clinics was quite hostile. Most of the co-op disappeared quite quickly. There were numerous challenges, but one of them was Like, for example, having a lay board governing a healthcare facility is a big challenge. Most importantly, also the organized medicine, like the medical association, the provincial medical association was not in favor at all of that kind of organization, both regarding the model of care proposed with physicians being salaried, for example, versus fee-for-service. I'm going to talk about that a bit later. And they were not fond of the governance model as well, with patient taking part to the governance of the organization and having a say in the healthcare services. So for that reason, most co-op disappeared, and SCC is today one of the 4 remaining co-op, and by far the biggest one. It has an annual budget of approximately 18 million. It has 170 staff member approximately and serves around 17,000 users. So yeah, that's it. I think that's all I have to say for that. Since its creation, that organization, that clinic, though, the SCC has been at the forefront of innovation, right? As I just said, its doctors are, and all the staff are salaried versus in the rest of the system, physicians are paid via fee for service. It means that every medical act that they do, they bill it to the Ministry of Health and get paid for like each separate medical act, right? Which is a very different philosophy, because under that fee-for-service model, you do not really have the time for collaborating with other healthcare professionals, time for education maybe, and you're in constant pressure with the cost of life raising to rise your salary as well, right? When you're salaried, that model of payment allows for more, let's say, collaborations and involvement also within the organizations, and we'll talk about that later. But yeah. So that's the one thing. Another thing, SCC has been very innovative with its model of care. It has been multidisciplinary and preventative from the start, whereas in the rest of the system, we're still, especially at the time, very physician-centered, with most of the primary care being served through physician-led practices, and in a more curative approach. So at SCC, they quickly recruited other life health professionals such as physio, occupational therapy, mental health counseling, nutritionists. They have also a lot of preventative programs for different groups and different subpopulation, let's say. Another key feature is that all services provided at SCC are free. One of their key, let's say, ideas that of access for everyone who needs it. And of course, a fourth key feature is that as a co-op, they of course promote patient participation, participation both in their own healthcare, but also at a larger level in terms of care organizations and health services, both at the level of the Saskatoon Community Clinic, but also more largely with regard to the system, let's say. So to achieve that, so all the users can become members. Actually, everybody can become a member of the Saskatoon Clinic. They have currently approximately, if I'm right, approximately 10,000 members. Those members, they can participate to AGMs, they can elect the board of directors, they propose and vote for resolutions, so they have a say in the way the clinic functions. And they obviously can sit at the board if they get elected. Just a quick note, that board at the clinic was, of course, at the beginning, when it was a more like tiny organization, was more hands-on, it was more of an operational board. It's now more focused on a more strategic oversight type of board, I would say. So that's it for that slide. Of course, SCC has been evolving importantly since its creation. It has grown immensely. As we have said, it has now 170 employees. And its population, the population it serves, has also been evolving a lot. In 62, it was mainly middle-class population. In 75, they opened a second side in the west side in the inner city, where they serve a more low-income and housed population, um, coming mainly from First Nations, some refugees populations. So populations that are facing complex health and social issues, requiring a different kind of model of care, maybe more flexible, that have poor healthcare conditions and poor access to healthcare services and other services. And now that population is like representing 25% of users at SCC. And as the clinic administrator was just saying the other day, at Westside, we take care of the sickest of the sick, which is quite what the research strongly confirmed. So about the research now, as I said, I'm just going to share the main results. Not able to go into details there, but so the result really confirms that clinic SCC is a key community stakeholder. It serves a complex, underserved population, and by doing that, it fills the systems gap in terms of like the patient population they serve, like a large part of it is not, let's say, profitable for private practice model of care, as it's asking for a lot of coordination with the rest of the system, like for social and healthcare services. It also asks for more opportunistic care, sorry, more time from the physician. All of that private practice can maybe not offer it, like certainly not offer it. Um, Another key result, I just like to share that, but doing conducting interviews, I've really been impressed by, I think almost all interviewees expressing a sense of pride being associated with the Saskatoon Community Clinic or working there or being a patient. So interviews were conducted with mainly like the staff, management team, the board of directors, and few patients. Yeah, satisfaction was high. Um, Also, the survey, patient experience survey, showed that SCC patients have a higher satisfaction in comparison with non-SCC patient with for the same type of patients. They were more satisfied of the quality of care they received, the coordination of their care, the duration of the appointments, and the physician attitude as well, things like that. So interesting. Finally, well, not finally, but additionally, the results also shows that SCC has had, I was saying it, a pioneering model of care and of governance from the onset. Its key features are it offers comprehensive preventative care. It focuses on patient participation and it's an organization that is highly responsive to the community. And all those key features are actually what we find in models of care that are promoted as more efficient and that we try to when we try to transform the system right now to address the primary care crisis, we try to go in that direction actually, which yeah, SCC is doing that since 60 years now. Um, Next slide. Okay. So in achieving what they've been achieving, SCC cooperative governance has been quite decisive. It has allowed them multiple things, but among others, it has allowed them to preserve their autonomy in the system. So working according to their own value and beliefs and offer services and programs they feel like needed and maybe react more quickly to the community needs. Versus if they would, for example, be one of the public healthcare facilities or things like that, and had to answer to the provincial authority or something like that. Um, that governance, that cooperative governance, also allowed them to stay innovative, with patient directly sitting at the board and being able to, or community members sitting at the board and being able to point the needs of the community, and yeah, being community responsive. Um, and even though co-op governance has been described as time-consuming and challenging sometimes, taking more time to make a decision, it's just because you have to gather everyone's voice in there in the decision-making processes. And that co-op governance is what it's allowing that to take into account every stakeholder's voices. So the family physicians, the other staff, the community, the patients, also the health authority has a voice in there because they're obviously funding part of the programs that SCC offers. So it's an interesting model of governance in that way that um, all the voice can come together and yeah, negotiations are at the heart of the decision-making process. Um, However, even if that cooperative governance model has been decisive and is quite important, today's I mean I describe it as a new crisis. It's maybe of a strong word, but it's just to highlight that SEC is facing some challenges as a co-op, and I just want to highlight some of those challenges. So one of them would be a decline in membership participation, and I think that's a typical issue in co-op after a certain time after its creation. So yeah, we see a lack of participation of existing members in the co-op. Also, the existing membership is getting older, and it's hard to recruit new young member that would be who would be let's say motivated to take part to the let's say the membership or the board or something like that. Um, it's hard to recruit. I mean, there is no room for new patients, so that's not really an incentive. So I could become a member, or you could become a member if you're not already, uh, but you will not be able to benefit from SCC services. So that's quite unconvincing, maybe. And otherwise, even if there was room for that for having new patient, there is no direct benefits of being a member, so no direct incentive. Um, I've also heard during interviews, healthcare is in a good place right now. So it's funny because it's also in crisis, primary care. But for those who have, I guess, family physician and are receiving care at SCC, I guess healthcare is in a good place. So the question was like, why engage if you're happy, right? And yeah, another challenge in terms of governance was the membership representativeness, which is a key, really a key challenge. So West Side population, which counts for, I was saying 25% of SCC services and population, West Side is not really represented in the decision-making sphere at SCC. So the board is mainly or users, so slash patients coming from the downtown side, or some of them are not even users. They are members who are not receiving care at all at the Saskatoon Community Clinic, but more like community members. So the question it leads to is, yeah, it calls into question the legitimacy of the organization in a way, like the funding ideal of SCC is that of shared governance. So what legitimacy does the board, let's say, have to make a decision on programs to serve a community they do not really represent, and how to remain community responsive under those conditions. In addition to that, there are other, I'm just looking at the time. Okay, I'm a bit over. It's okay. Okay, in addition to that, there are other challenges. So they have been pressures for SCC to integrate Saskatchewan Health Authority at some point. I've heard also, yeah, some of the pros, like it's hard for SCC, like you have autonomy when you're not integrated to that SHA system, but you lack maybe connectedness with the rest of the system in terms of data sharing, funding, or yeah, things like that. So yeah, obviously the big cons of integrating the SHA, for example, would be loss of autonomy for the organization, which has been decisive, as I was just mentioning, in how SCC evolved and since its creation. Another challenge is that SCC needs to keep growing to address the community needs. I know they recently acquired a new building. I'm not sure if they had new money that would go along with that to recruit new doctors or new healthcare allied health professional staff. But the question would be, how can they keep growing to serve that community? And we know the needs of the community are rising, while keeping a local anchorage and maybe a local governance. So there is a need currently to reflect on the mechanisms at SCC, the mechanisms to implement, maybe to reactivate citizen or membership participation, and to preserve that a shared governance within the organization and make sure that they remain responsive to the communities that they serve. So that's it, I think, for the presentation. So as I said, I'm eager to hear a bit your questions if you have, or comments or ideas or anything, but I will leave the floor to Marc-André, and I think I should stop sharing my presentation, right?
Yes. Thank you so much, Coralie. That was really, really great. And I know people are going to have a lot of questions, but I actually think we're going to do a breakout after all. We have a nice crowd here. We're going to do a breakout till 12:40, so about 12 minutes, Dasha. Groups of three. And we're going to ask you just to introduce yourself to your fellow breakout participants, and then share a little bit about what you found interesting or surprising about the presentation. And then maybe think of a question or two that you want to bring back to the plenary group when we resume. So, Dasha, if you can set up the groups for people, groups of three people, to reconvene at 12:40. Thank you very much. See you in a bit. All right, welcome back, folks. I hope you had a good, engaging conversation like I did with Steve. I learned a lot about process improvement and in healthcare. Thanks for sharing that, Steve. So
Yeah.
we're going to open it up to the Q&A here, general Q&A for the audience, and I'll just look for open raised hands if you can use the raised hand function. Or yeah, that would be my preferred approach if folks can do that. And I'll just keep scanning here. Steve, I called you out, so I don't know if you want to just start us off.
Okay.
Your microphone's probably unmuted already, so go for it.
Yeah. Yeah. I was wondering if anybody around the virtual table can talk about, you know, the what's it like with the Saskatchewan Health Authority wants to integrate the co-op, SCC into the greater health system. Like, how's that going? Because I do process improvement in healthcare, and there's a lot of cultural characteristics of legacy healthcare that are not good, and I'm wondering how those are being handled
Great
in
question,
those
Steve.
discussions. Yeah.
Thank you, Coralie. Do you want to try, or Murray, did you want to weigh in on that, or were you asking? That was a separate question. Okay, Coralie, I'll let Coralie, and then we'll go to Murray for the question. Go
Yes.
ahead, Coralie.
Sorry, Steve, I'm not sure I heard everything. It was the sun was cutting, but you were asking so how that would go if they were to trying to integrate the Saskin community within the
Yeah.
SHA. Yeah, I don't know. I don't have an answer to that. Obviously, I guess that would be a very challenging process. I guess we just discussed it. We just discussed that quickly in some of the interviews about the pros to doing that, like in terms of managing the funding and reporting, and also in terms of data analysis and all of that. Okay, I'm trying to see if yeah, okay. Oh yeah, you're here. Okay, that's weird. I was searching for you. um, but yeah, I guess that would be a very hard process in terms of also culturally both organizations are working, I guess, quite differently. So yeah, it would be a lengthy and a hard process, and maybe a large part of the staff wouldn't be happy with that, I bet.
Yeah.
Thanks, Coralie. Thank you, Steve. Murray, I think you were next, so I'm going to go to you.
Yeah. Thanks, Marc-Andre. Coralie, thank you very much. That was wonderful. Very nicely laid out. One of the things, and we talked about this in our breakout group, so it's partly coming from that. You highlighted, I think rightly so, this kind of governance challenge where the users really are not the ones making decisions anymore. Is it time to actually change the kind of discussion around the community clinic and stop calling it a co-op and instead actually just acknowledge what it is and the strengths and potential weaknesses of what I would call a nonprofit model. As some of the people on this call know, I'm on the board of a nonprofit who provides services to people with intellectual disabilities. It's not a co-op model, but there are some real advantages to having a board with certain characteristics that are engaged with not only that community but the other sort of things that have to go on to provide services in that arena. I'm not saying it's perfect by any means, but it's not a bad model. Is it time to actually acknowledge that the co-op of the clinic has actually evolved, and it's evolved into something different, and it's got some real strengths, and you start to think about it in a different way, and that might actually give you a way of being able to find a way to introduce it into other parts of the system, much like Steve was asking. But as long as you continue to think about it structured in this way that you're never going to meet anyway, are we actually creating some barriers to meeting what is really important, which I think is a different compensation method, a different method of treatment, wraparound services, a set of other things that are actually really critical, and we don't want to lose those. So just some thoughts.
Yeah, thank you,
Coralie, go ahead.
Murray.
Yeah. Go
Yeah,
ahead,
sorry, Macaulay. Yeah, thank you, Murray. That's of course the most important point of the research. I think I don't have an opinion on that. I don't know. It's just questions I keep asking myself. Obviously, it's true that I think we can say that now it's and when you look at the literature about co-ops in healthcare, it says that, I mean, I'm not a co-op expert, but it says that member-led co-op tend to with time transform into community-led organization, like non-for-profit community-led organizations. So I'm not sure if it's a good thing to admit it or to keep fighting for like staying a co-op and having that patient involvement piece, which is maybe a bit more emphasized into like the co-op structure than in a community-led organization. I don't know. So that's a really good question. I feel like I'm not sure if admitting that and I mean there are different steps. I guess you could admit that and call yourself a community-led non-for-profit and still remain out of the Saskatchewan Health Authority a system, or you could integrate it and have a different governance way of functioning. So I'm not sure what's the best solution. I don't have an answer to that question, but if other people have, and I feel it's not my job also to have an opinion on that. But it's true that the question I was also asking myself is that what would it take for the co-op to be really a co-op? And I remember one of our first discussion, Murray, where I was telling you, is this really a co-op under these conditions? And then does it do more? Does it hurt more than it does good by calling yourself a co-op if you're not really representative of the population you serve and blah blah blah. But yeah, I don't know.
All
But thank
right.
you for the question.
That was fun. Isabel, I think you were next, so I'm gonna go to you next, and then Jeremy, and then June. Go ahead, Isabel.
Thank you, Marc-Andre, and thank you, Coralie. You know, as a social researcher, when I see these broad statements, I want to see the voices. And so I was actually surprised that you didn't represent the voices of those who participated in the study. And, you know, when you talked about not having enough incentive to engage, you talked about healthcare being seen as in a good place. And I understood you at the time to be talking about the broader system, but perhaps I misunderstood you, because that would certainly not be a widely held view in this province. Anyway, I just wondered, you know, the selection of emphases didn't seem to sit with some of the evidence you shared. So high levels of satisfaction, but my goodness, there's a major challenge here. So I just wondered if you could speak to that.
Yeah, of course. So you mean a gap in between like the higher satisfaction and the fact that there's no incentive for people to take part to the organization. Well, so yeah, that's a good point. First of all, Isabel, thank you for highlighting that. I'm usually using quotes. I don't know why I did not this time. Maybe because I only had 15, 20 minutes and I focused on high level results maybe. But these are the results I'm using. I can hear the voices in my head, like during the interviews. So people saying that there is no real incentive of becoming a member of that co-op. Would be, these are not my words. These are words that I've been hearing through all the interviews. Healthcare being in a good place as well. These are words coming from interviews. And I think that people just feel like, well, we're not in a crisis anymore, right? Like in 62, and people have, like, large part of people have access to care and are yeah, those who have family physician, right? I'm talking about that. And at SCC, if you're at SCC, you have a family physician, you have all the care you need. So, and it's all free, so you do not have any complaint maybe, and you do not engage because you do not see like this the healthcare system as it is, like the situation as it is, more largely. So so that's maybe explaining the gap. I feel also like I have to precise something about the highest satisfaction. The patient experience survey, the SCC patient who completed the survey were mainly coming from the membership. Most of them were coming from the membership. So it's a strong bias. We still match them with same age, sex, income level with the general population in Saskatoon. Hey, but these are still people who knew the clinic from like decades ago and who have been engaged with the clinic maybe, or yeah. So that's maybe explaining the difference between those two results. I don't know if I'm answering the question correctly. If it's clear, I'm sorry.
I think we might have to have another conversation. This is fun. Okay, Jeremy, your turn.
Thanks. Hi, everyone, and hi, Coralie. Thank you for the research and the presentation. This is obviously very important to all of us living in the province and interested in services like this. I'm wondering if anybody on the call today knows what the SHA's motivations for wanting the clinic to merge would be, because I think that the purpose of what we're doing is going to determine the outcomes. If it's profit based, if it's motivated by outcomes, is it motivated by prevention, harm reduction and prevention and reduction of dependence on the system? or is it just trying to, eliminate or reduce or dilute the statistics and the numbers? And I think it's important to a cooperative model when it's tax dollar funded through the Ministry of Health. We are all contributing to it through our tax dollars. So it's interesting. There's a lot of nuance and perception of, centralized versus decentralized and what a cooperative model could look like. Maybe there's a little bit of wiggle room there, but what is the SHA's motivation for wanting to consolidate?
Yeah, thank you, Jeremy. Actually, I don't really know more than that. I didn't conduct any interviews with the SHA formally, so I would be less able to speak about that than, for example, board members or the administrator. But and I was just seeing Jason in the chat, who
Yeah, he's
capacity it is.
suggesting capacity, but wouldn't capacity be then increased if they're trying to absorb it versus now it's out of their scope, so they wouldn't be.
I think
I think capacity, Jeremy, in the sense of it's the clinic has challenges because the SHA will say, well, no, you're not part of the SHA. You get your funding from the Ministry of Health. And the Ministry of Health says, yeah, but you're a primary care clinic, go talk to the SHA. And so even within the government, sometimes there's a question about, well, what do you do and how should you treat this? And we even have differences in the funding among the community clinics within the province, because in some cases there's a capital allocation that the ministry grants against leases. That's in the case in Regina, but not in the case of Saskatoon, where we own our own property. And there's some disequity there as well. So there's a lot of issues, but I think they stem from it's just confusing and complicated for the ministry because they don't have anyone dedicated to looking at us.
so. That's what I was about to say. Like coordination, maybe one big issue in terms of SHA has to coordinate healthcare on their whatever number network, primary care network, and having such a big organization out of you're not hands-on at all on how they work and on their process would be a big complication, I guess.
Okay, thank you so much. I'm going to get June and Cheryl to each put their questions out just because we have about 4 minutes left. June, I'll start with you and we'll get your question, then I'll go to Cheryl and then ask Coralie to handle both of them. Go ahead, June.
My question's already been answered. Jeremy asked it and I got the answer I needed. So thank you.
Wonderful. Thank you, June. Cheryl, over to you then. You got the last of our time.
Thanks. Mine is actually not focused on that. My question is I think as a former chair of the board of the clinic back a number of years ago, the clinic was much more engaged on an activist level in the community, on a member level, like member to member, seniors committee, advocacy committee, education committee. All of these committees existed and we're part of that cooperative model. Today, none of those committees exist. We've become much more of a corporate kind of structure, governance board. And so in its evolution itself, it's moved away from that sort of connectivity to the members. And I don't really see, I must admit, I've been scanning your report. I don't really see any emphasis on any of those areas as a member engagement tool, which was in essence where we recruited our board members from. That's where I came from when I became part of the clinic. I came into the advocacy committee. They said, hey, you're really engaged. Let's move you up to the board. And so we've lost that pathway for young members, new members, interested members to become part of the process. And in some way, this is the story of many, many different cooperatives. We lost those tentacles into the community. And I don't think you covered that. I did a quick Google search of search of the words and terms you're using, and I didn't see any of that inside the report. That is where I see some of the real substantive changes in the clinic. And it's continuing to move as it's pulled into that healthcare conversation. So that's my question is that where the gap is? Is that what really is missing? Is we can talk about it as a corporate structure, we can talk about healthcare, but the clinic always was as a cooperative, much, much more than just that.
Yeah, Cheryl, thank you. That's a really good point, actually, that I don't think we really addressed in the report. I mean, the decrease of activism was highlighted during the interviews, and I think it's maybe somewhere briefly mentioned in the report. But I think it's indeed a key factor, maybe. And yeah,
I just want to add one last thing is no one wants to sit on a board. I mean, I sit on 10 boards right now. They're all boring. They're all numbers. They're all boring. But being on a committee of activists is really fun. So
I think
that's-
that yeah. No, I agree, and I think that's also when this quote that I mentioned, healthcare is in a good place right now. So that's maybe connected to that kind of discussion where some people find that healthcare is in a good place for those who have access, and they do not see any reason for more activism. Which I remember saying to that person, it's funny because we are in a complete crisis in terms of access and many other things in primary care, but there is no move around that. So yeah, that may be a good point. Thank you.
Yeah, that was a great question and great conversation overall. I'm reminded, Coralie, in the 80s from the newsletters. We went through the newsletters of the SCC, and you could see they declared the clinic a nuclear-free zone or something like that, right? There was that activism was showing up in all sorts of ways that were a little remote from your day-to-day kind of primary care kind of services. So that's really interesting. Before everyone runs, I just want to flag that we first of all, thank you, Coralie. Thank you all for being here today. What a great conversation. I feel like we want more. I just want to say that we do have our next co-op conversation. It's always on the first Wednesday of every month. Stan Yu is going to be talking about co-op camps. We did a survey of over 350 people, I think, across Canada on their experience of co-op camps, and we're going to kind of get the results of that survey, which happened earlier this year. So that's really exciting. On November 20th at 1 p.m., we have our Ferdian lecture with Candice Minot. She's going to share her research findings on how credit unions have integrated call to action number 92 from the Truth and Reconciliation Commission into their practices. And on December 17th, we haven't set the time yet, but it'll probably be 4 o'clock. We're going to have Marie Bouchard, a noted and well-known scholar on cooperatives from Quebec, coming to share with us some thoughts on the social economy. So we have a really packed and very interesting agenda ahead, and I hope many of you can join us for those talks as well. So thank you again for taking the time to attend today's co-op conversation. We hope you have a great rest of your day. Bye, everyone.
Thank you, everyone.